So it now gives me, again, great pleasure to invite Ray O'Sullivan to talk on cost effectiveness. As you will all know Ray, he doesn't really need an introduction. Ray is a consultant gynecologist in Kilkenny. He did a fellowship in laparoscopy and urology in Sydney, and his main interest is actually in training, endoscopy training. It's been a privilege and a pleasure to work with Ray over the last decade, and now he's going to talk about money, another subject close to his heart.
Very close to my heart. Thanks, Walter. It's difficult to discuss the financing of the Irish health system because we're given about €13.5 billion from the government to do the work that we do, and we're told get on with it. And how we, kind of utilise those monies is pretty well up to the hospitals, and very little gets dictated by ourselves. So when talking about the change and the move from the current model of care, which is inpatient or day case, to the outpatient setting, it's difficult enough to quantify, what savings might exist, because our paymasters will tell us, well, there's no difference. It doesn't matter whether you do it in an outpatient, whether you do it in the hospital. The money is still just the way it is, and so as such, there's no benefit to moving towards outpatient hysteroscopy. But things will change, and I'll talk a little bit about that. Oh, butter. Sorry, Nancy. Just chilling. Just chilling. So, is it cost effective? We know from models around the world and studies that have been done, yeah, it is cost effective to get our patients into the outpatient setting and the ambulatory setting. What we need to understand is that outpatient hysteroscopy is a best practice. It is an internationally accepted gold standard of care. And I suppose on a clinical level, we shouldn't even be entertaining taking our patients to theatre. It's not right. And I think our paymasters need to understand that. So whatever about the financial argument, it needs to be a clinical honesty that we kind of take our patients to the outpatient. So the guidance on this and best practice in this would, from the BSG and from the RCOG, would say to us that all gynecology units should provide a dedicated outpatient hysteroscopy service to the aid the management of women with abnormal uterine bleeding. There are clinical and economic benefits associated with this type of service. So it's a tautology. We know this is the case, and as I said, it's remit was not to force this issue. Outpatient hysteroscopy should be conducted outside of the formal operating theatre setting, and we've heard all the reasons for why that should happen. Outpatient hysteroscopy should be performed in an appropriately sized and fully equipped treatment room. Again, we've heard all about this morning. We know this is the gold standard, yet we don't commonly employ this. The healthcare professional should have necessary skills and expertise to carry out hysteroscopy, and that's what this course is about. So we need to build up from the ground up. There are some units around the country that have pushed forward with this, but most of us haven't, and these are the reasons why we should. And written patient information then should be provided to the patients and consent, etc. It's very important. So let's look at the typical journey of the patient with abnormal uterine bleeding in Ireland. So there's an outpatient visit with associated costs. They often go for an ultrasound, another outpatient visit. They have a general anaesthetic, a day case, back to an outpatient visit, and also what needs to be included there is the loss of productivity. So let's look at this. I mean, they do turn up, the GP sends in the referral, they wind up coming to an outpatient to sit in a waiting room and wait. They get to see us, they get to be examined, visit number one. Then they're probably sent on. In some hospitals we will do at the clinic our own ultrasounds, other units they won't. They get sent to an ultrasound department, so they get to check in at another reception, wait again, see a guy and often the radiologists are very poor at doing pelvic and gynecological ultrasound. We've all seen it. Seen the scans that said uterus is small, patients with no uteruses. So you get these kind of. So our radiology colleagues often aren't of assistance. Patient then comes back to the clinic. They check in at reception. They sit down and wait again. And I don't know what's wrong with you. Why are you bleeding? I have no idea. So, do you know what I'm going to have to do? I'm going to have to bring you as a day case into hospital. So you're going to lose an entire day now of your life. Because you're going to be checked in, and everyone's going to do 58 million checks, and they're going to ask you 85 times what your name is, what your date of birth is, where you're from, what your cat's name is. And then you're going to come into theatre, and we're going to knock you out, we're going to fully put you to sleep, and then you're going to recover for a while, and you're going to lose an entire day's productivity there. Then you've got to go back to the clinic again, back into reception, sit around and wait again, and you're going to see a kind of, a scab-faced, as Joe's going to say, we don't know. But this is realistically a journey that many of our patients make, and it is wrong, and it's cost at every point in that. And studies have shown, I think I'll talk about it later, is that typically if you go to outpatients, you lose 0.8 of a productive day. Whereas if you go through the traditional model, you lose 3 days of your life to try and get investigated for something that can be done in an outpatient setting. So again, the outpatient setting, it's far easier, isn't it? It's far quicker, it's far slicker, it's far more defined, it's far more refined. So you check in at your lovely reception desk, you meet the doctor, you have your examination, your scan, and your hysteroscopy, you discuss the findings, whether nothing needs to be done, whether something needs to be done. It's all done in one visit. So I could probably explain this to even the dumbest Minister for Health. Oh, geez, we have one of those. And explain to them that this is far better for our patients. And I think it goes without saying. How do we look? If you look at the HYPE data, which is generated by the ESRI, there's lots of tables and lots of things, and you can search the database. But pulling out this, it's hard to read this, but I just did this for you. In the 2012 HYPE data, which is for public hospitals, I should have actually kind of said to you, how many women do you think get general anesthesia in this country for examination of the uterine cavities? It's almost 8,000 women a year in Ireland are having general anesthesia for this simple outpatient. It's just ridiculous. And that does not include the private. So we 4.5 million. So and probably throw another 3,000 or 4,000 on top of that going through the private health system. So you're at 10, 11, 12,000 women are coming in, losing days productivity. And as I said, 3 days, 30 to 40,000 days of lost productivity by the women in this country every year. So again, these are costs that are very difficult to define in the Irish health context. But I just thought it'd be interesting just to pull that data out for you and just kind of so we can see how big this problem really is. Now, Steve Burrell from Luton and University College London, I've taken some of his slides now, which he presented in Brighton to BSGE, and just looking at where maybe our nearest neighbours are at, how they've looked at this problem, and how they kind of fund the system, and how they will drive the patient away from the day case and operating room out into the outpatient. So in the UK, as of the most recent figures, about 39% of patients are done and have their hysteroscopies in outpatient. So there's still 60%. There's room for manoeuvre, and it's acknowledged in the UK that there is room for improvement. What's the rate in our units currently? When we look around the room, it's very, very low. Is it anywhere nationally? We're nowhere near this. And then, often there's a bit of a skew. We all wind up thinking that, we got Justin Clark here, and geez, all of the UK must be at the same races as he is. But no, you often find dedicated units, people that are interested to push this on. But in the smaller GTHs and the smaller hospitals, you find nothing's really happening. So they have the same challenges over there that we have. The Department of Health in the UK considers that 80% of their patients could go to the outpatient setting, and that we can achieve these higher rates. And I'll talk a little about tariffs in a minute, but it's kind of a process that shouldn't happen overnight. It can't happen overnight. It's going to be a process that will have to evolve over time. So, looking at some of the figures, what was going on in the UK, diagnostic hysteroscopy, or in the clinics or in the theatres, 472 quid for that, and if you do a bit of operating with it, it's 800 quid. Do both in a session, you get 893 quid. You could do them separately and get quite a bit of money. This is what was going on. But it's all of this is good for patients, but the UK decided to introduce new tariffs. And what's quite interesting with this, this is just another element of the costing, that 40% less staff, you generate more money from the commissioning bodies there. There's faster overall rate, speed, and turnover when you go to the outpatients. The resections can be quicker, and especially with the newer technologies that we have now. This is what really, I think, is going to change things. We've got technology that allow us to do straightforward, simple procedures in the outpatient setting. So, looking at kind of inpatient theatre care in the UK, and then, it's very well calculated. How your theatre time at £20 a minute. They were being paid. Hospitals were being paid €260 for it, and when you work out how much the cost was, they're actually losing money per case going to the theatres. And then if you did a hysteroscopic procedure, there was still a loss maker on that. But if you move things to the outpatient setting and with newer tariffs, there's profits to be made for the hospitals. And now this is a funding model we don't have in Ireland, but I'll say it in a second, I'll talk to you in a second. It's going to change. It's going to change, and we need to start looking at this. So overall, with the changing tariffs, they've moved to a situation where you get paid far more for doing an outpatient hysteroscopy than you do for bringing in a patient into the OR, which is great. I mean, it shows that somebody's listening somewhere in the UK, and we've got this challenge here in Ireland. We've got to get somebody to listen to what we're talking about. So overall, with patients then that have something going on and they see a treat, you make £699 profit per patient. And that's significant over a long period of time in individual hospitals, and you've added up in a large number of hospitals. That's a significant saving across the NHS if you move things to the outpatient setting. Where I'm coming from now is that there's going to be a change in this country. I don't know if anyone's read this document, Money Follows the Patient, the discussion document from the Department of Health. Has anyone seen it? Has anyone read it? Anyone read it? It's amazing that nobody has read this. Probably one of the most important documents that is going to drive change. You read it?
I tried.
All of it?
Not all of it. You can't see nobody looked at it.
I brought this to the Institute to try and get a discussion going around the very fact that money will follow the patients. The funding model will change. So we will be paid per item, per case, per patient that goes through the system. And the funding model, this is now quite advanced in its genesis, and it's amazing medics don't seem to really know this. And the one worry I have is that the tariffs that will be associated with individual procedures will be reflective of what currently goes on now. So they'll take basically out the private insurance code book and say, okay, a hysteroscopy, €182, and that's what they will apply whether you do it as an inpatient or an outpatient. So we've got to be very careful that we get involved here at the National Information and Pricing Office, that we get knocking on this door to ensure that we don't create the situation that used to exist in the UK, that we actually create a financing driver for the push into patients to the outpatient setting. So, as I said, in Ireland, it's not easy to quantify the savings, but in this new model, which the first element of this will probably come in 2017 and will be the full funding model by 2020. So for many of us in this room, this is going to be a reality for us, but it's an opportunity as well. The other people that we should probably be attacking are the private insurers. They don't seem to worry too much about an anesthetic fee, a hospital fee, a consultant fee. They say, okay, that's fine, we just add it up. They should be also approached because they could drive the change for us as well, because they could insist, just like the NHS did, that the patient's done in the outpatient setting, we'll remunerate the hospital and you more for doing it that way. So the private insurers may drive things too. So currently in Ireland, it's somewhere between €700 and €1,000 per day. Whether you're a day case for an inpatient is the range there. The cost excludes other things like consultants' fees, outpatient visits, superannuation. So this is just a crude costing for a bed in the Irish system. So we're looking at about 8,000 women with savings like this. If costed, it could generate 8,000 or €8 million for the system. Now, as I said, this isn't a real value. It's not actually kind of something that currently in the system. But in the new funding model, there could be an 8 million saving or an 8 million profit for all of us working in this area. And also then the indirect and intangible costs. So the patients having to get childcare, people having to take time off work, people having to come to visit, take you to and from the hospital, 3 days loss of work, all those kind of things. There's huge costs in that as well. So the cost savings for the patient, tangible and otherwise, are quite significant. There is this other side of it. We have to accept that 10% or so of the patients that we do office hysteroscopy on may need to come in and have a GA case, whether we can't get into the uterus, whether there's larger pathology or pathology we can't deal with in the outpatient setting. So maybe 1 in 10 may have to come in. But that's part of the discussion that you need to have, or we'll be having, with the Department of Health and the Health Service Executive. So outpatient hysteroscopy, without any doubt, is cost effective. In many countries, the Australians reckoned that they would save $60 million a year by pushing the 80 or 90% of patients that should be in the outpatient setting out into the outpatient setting. There is, however, an initial capital spend, and I think our paymasters will need to understand that. If we're going to have nice small hysteroscopes, good vision, nice stacks, and there's beautiful systems out there now that are really compact and they're really transportable, but they're going to have to understand there is initial capital spend. There's also going to be a little bit of spend on training, because as we've heard, the approach to the outpatient patient, the awake patient, is very different to the anesthetized patient. And there is a training aspect to that. And there are consumables, and that'll all have to be costed in. So I think where we need to go is, like we're starting with here today, is we start with the training and competency. We need to introduce a training program and a competency element to that. We also get to the hospitals and the government to acknowledge there's an equipping cost to get them to put their money where their mouths are. Then we start doing outpatient hysteroscopy, diagnostic, and then with time move to a see and treat model. So this is the progression that we should probably need to employ in this country from now on. And hopefully today, after a decade or more since the last hysteroscopy course was run in this country, hopefully today will be the beginnings of pushing this very important issue through for our patients. So I'd like to be able to say I could give you big figures on how much we'll save and things like that, but at the moment in the Irish funding, the Irish health system, it's not possible really to do that. But I hope you get a sense there, and we all know this anyway, that the current approach is wrong. It is consuming of patients' time and money. It is consuming of our time and money, consuming of the hospital's time and money, and hopefully we will move then towards a model that will be far more cost effective. So thank you very much.
Okay, first of all, could I invite Michael and Jean-Luc to the front to take questions over the next 10 or 15 minutes. There's one other thing I wanted to add to what Ray said, and that is that I can't remember the lady's name who died in Galway recently in relation to a Savita. I think that one of the things we might start saying to the fund holders is that if a patient dies because of a general anaesthetic or has an anaesthetic complication of significance, it will be indefensible in court if that patient had a diagnostic hysteroscopy where there wasn't a difficulty that was anticipated. And I think it may be that we'll have to wait until a case like that happens to persuade them, but I think they're becoming more and more sensitive to the reality of complications associated with unnecessary intervention. I think we should use that argument as well as the economic one in trying